University Hospital. He joined the St. John's staff in 1997. He's developed an interest in telemedicine and will speak today on avoidable hospital readmissions and the role of telemedicine.
My topic today is how to avoid hospital readmission. That's everybody want. Actually, it's Google other than want. At least that's it. Healthcare is changing. It is an evolving relationship between the patient and doctor, and there is more. We can expect more e-visit. There's more patient-friendly hospital like St. John's, I guess. Huh? And there will be new approaches and how to save the. Medicare requires us to save money. At the same time, they want us to provide better care. I just want to give you some statistics regarding the what's going on right now in the readmission rate. There's 20% of the people who are discharged from hospital are readmitted within 30 days. And 90% of those 30 days readmit patients are unplanned and result of clinical deterioration. Out of those 20%, 75% are avoidable. It costs Medicare around $12 billion a year to Medicare spending. So you can see what they want from us to stop this abuse. There is an initiative. Patient initiative in National Partnership for Patient goal of reducing hospital readmission rate by 20% by June of 2013. And California goal is to reduce readmission rate by 20% by next year. And if you can see the data quarter ending from 2010, fourth quarter to first quarter of 2011, there were 7,641 discharges. Out of those patients, 22% was readmitted within 30 days. And the 26% of those patients was coming from nursing home. And 23% are coming from home health with home health agency. And there's only 16% coming from when they discharge directly to home. I was involved in this initiative because I was involved in an initiative to reduce the hospitalization among nursing facility residents. We applied for the grant in June, and we're expecting the grant result this month sometime. As a part of the grant, the CMS wants us to show that 20% reduction by the end of 2013. And you can see what CMS wants. CMS wants us to hire a staff at each nursing facility. They want us 15 nursing facility, 100 bed or more. Either we should hire a nurse practitioner or physician assistant who will be available there at all time, at least 8 hours a day, and can see the patient whenever is needed. At the same time, they also encourage us to use telemedicine. Communicating between the primary MD and the nursing home patient, and also between the ER physician and nursing home patient. And I can tell you this thing, the changes are happening. Medicare only allow a primary care physician 1 visit a month for telemedicine. But they're allowing an ER physician every 3 days, they can see the same patient. It means they're taking away the business from the primary care physician, giving more to the ER. So ER pre-evaluate the patient before they even admit the patient or allow them to come to the ER. You will see dramatic changes, and these changes are happening right now. It's not going to happen next year, it's happening this year. And then research, Medicare, this is all evidence-based. They already have done the pilot project, but we are doing it. We are implementing a evidence-based research. They show 45% of the hospital admission could have been avoided, accounting for 300,000 potential avoidable hospitalization. 2.6 billion Medicare expenditure in 2005. And at the same time, they want to penalize hospitals. As of effective October 1st, 2012, 2,211 hospitals in the United States will be penalized, out of which 2,278 hospitals get maximum penalty of 1%. The penalty will go up to 2%, 3% every year, 4%, 5%, they up to 10 years, they're thinking of 10% penalty. They like to save costs by doing this thing. Now, what Medicare constitutes telemedicine? And now this is very interesting code from medicine, from the Medicare, and I want you to understand this code. The use of a telecommunication system may substitute for face-to-face hands-on encounter for consultation, office visit, individual psychotherapy, and pharmacological management. So if you have a patient at home and you do a telemedicine, it can substitute the face-to-face examination. And this is the actually code taken from Medicare directly. So we can use telemedicine in, for example, in the end-stage renal disease hemodialysis patient, we allow 4 visits a month. Out of 4 visits, 3 visits can be a telemedicine visit, and 1 visit has to be a real-time on-hands visit. And now the Medicare is already paying for this thing. It's not paying now, they're paying for a few years actually. They are increasing their payments. They are paying for 3 situations. Number 1 is real-time telehealth or telemedicine, where you have a face-to-face video conferencing. But at the same time, Medicare understands this thing that we as a physician also can abuse the system. So what they want us to do is to record the encounter and store in your electronic record so they can come back tomorrow and say, okay, show me that. You know, as the other situation is store and forward situation is a very interesting. Actually, it's only Medicare only allowed in 2 states right now, but if you can see this thing, it will be spread very fast even this year. In this situation, you send your nurse to patient home. She record all the data, examine the patient electronically, and put in the computer and forward the file to you. You can come back in the evening and evaluate the patient data. And this also get paid by the Medicare. Third situation is already been paying for a long time, like pacemaker check, cargo check, glucose check, weight, follow up by the health home for the weight and CHF evaluation. And these are the data that actually obtained from the Medicare website directly, and you can see these are the CPT code already there for telemedicine. They are CPT code included for the ER physician as of January 1st. So ER physician or ER nurse practitioner or physician assistant can do a telemedicine with the nursing home every 3 days on same patient. So to avoid the admission to the hospital. Currently, the following services are included, like inpatient consultation, follow-up, office visits, individual psychotherapy, pharmacological therapy, hemodialysis patient, you can do telemedicine, you can do a smoking cessation section can be done. And who are the eligible providers? Physician, nurse practitioner, physician assistant, nurse midwife, clinical nursing specialist, psychologist, and social worker. And where this can originate, the telemedicine, where you can do the telemedicine from, the office of physician, it can be a hospital, it can be critical care access hospital, it can be rural health clinic, or skilled nursing facility where I'm doing right now. And I'd like to show you what we achieve as a USMD Direct. I run USMD Direct, is a web-based portal. It means this thing that you don't need any software, you just go to USMD Direct /telemedicine and you can start your telemedicine service. And as a part of the service, what we provide, we can do a video conferencing. We can do a telehealth stethoscope. If you can see this thing, the stethoscope is just plug into the mic portion of your laptop or computer. You don't need anything else. Just put in your mic portion, start this, the browser, and here we go. So at the same time, we have this camera we use for the eye exam, we use for the throat, ear, nose, and we change the, I'll show you or demonstrate you later on, that this camera can do all the examination. Only thing I can, or my telemedicine cannot do, is palpation. And if you see, you can see the ear here, This is actually my skin over here, the throat here, and you can see we can provide store and forward. We're doing a remote patient monitoring, where means you can do 1,000 patients can be seen by one nurse at one location. They can evaluate them from distance. We integrated our system with the EKG lead, and we have, like, now Paul probably interested in this one. We have this single lead EKG equipment. It's very small. At this size, the patient can put their thumb up there. It automatically uploads to the patient folder. And so if he calls you 2 o'clock in the morning with palpitation, you know, hey, let me check whether it's really a palpitation or just you calling me. But you can charge it. So at the same time, we have 12-lead EKG, well-challenged EKG, which is here attached to the system. We have a CogniCheck system. We have other interesting equipment which is attached, which is really interesting, is the Withings blood pressure monitor. And this is the actually blood pressure monitor which goes to the iPhone directly, and it converts the iPhone into the blood pressure monitor. And every time my patient takes blood pressure at home, it uploads into their folder in our system. And then what you can do, individually you can say this thing, okay, if the pressure goes more than 120, I want to alert. Or if the weight goes more than 200, I want to alert. So system will generate the alert and send you a text message, Mr. John has blood pressure more than 180 today. And then you can go to his system, check what's his blood pressure. How can we use the telemedicine in nursing home? As a primary care physician, I can always check the ear, throat, and nose examination. And you know, the main reason patient call us from the nursing home is the earache. So I can go and check patient ear and see if there is anything going on with the ear or not. This is the tympanic membrane. The next call we receive from nursing home is about the skin problem. Like you can see one on the skin right now. Like cellulitis is another problem we see all the time. We can differentiate with the telemedicine. The other thing is the decubitus ulcer. You can see the wound, you can follow up on the wound. Same with the surgical wounds. You can see them accordingly, what's going on. And make sure I clean myself in the morning. This is my skin, you can see. The third reason they call us is about throat problem, and let me show you my throat, and you can see how clearly you can see the throat problem. Brush your teeth. The other reason we get called from nursing home is about the eye problem. Our patient woke up in the morning and his eye is red. Now we have to differentiate between the conjunctival hemorrhage, which need no treatment, and the pink eye, where you need a certain treatment you can give them on the phone, and then really conjunctival or conjunctivitis. Let me show you my eye here. You can see the whole eye. Also, the nurses call us when patients develop a cough or shortness of breath, and we can use telemedicine to listen to patient heart and lung sound as follows, so you can hear this. If I'm a surgeon or orthopedic surgeon, my main interest is to follow up my patient in nursing home to check their range of motion. In case of hip replacement or knee replacement, my main interest is just to see the range of motion. I like to see the wound of the patient over there, whether it's healing properly or not. This is the main reason for surgical follow-up. As a nephrologist, I will see more hemodialysis done at the nursing home. And what I can do, now I can do telemedicine to do my face-to-face evaluation, which is a requirement of Medicare. And also like a psychiatrist to do a psych evaluation in the through the telemedicine. And same way I can invite other consultant to do a telemedicine. Now you ask me about the cost of the equipment. Okay, the basic unit of USMD Direct is approximately $3,000, which include the 23-inch touch screen, a monitor, plus the video camera, plus the stethoscope, plus the otoscope and ear camera. Now you want to add the blood pressure monitor, which include the blood pressure and temperature, and pulse ox is another $1,300 or $1,200. And if you want to add the EKG, Welch-Allyn EKG, another $1,800 to the system. Basic unit is approximately $5,000, $5,500, which is the actual cost of the equipment. And the system will run on the Wi-Fi, so you don't need a T1 line. So T1 line costs $500 a month. So it's not. We are just using the regular Wi-Fi system for this this machine.